structure and or function of the right heart circulatory system that leads to suboptimal delivery of blood flow to the pulmonary circulation and or elevated venous pressure. Does this guy, can he deliver blood to his left side? Yes, is the answer, right? His wedge is going to be like 30. So his problem is not the ability to send stuff over. So by definition, he doesn't have right heart failure / heart failure. He just has volume overload and right-sided symptoms. And the number of people that get that messed up, and we had a big debate with one of the docs recently about this because they thought that cardiomems would not be beneficial in somebody with right heart failure who was this patient. So not right heart failure, right-sided symptoms related to RV. So what's going on here? So left-sided symptoms, you guys know. Exertional dyspnea, P&D, tachycardia, cough, hemoptysis, right? The lungs are congested. It's backing up from the left side into the lungs, and on exam, bivascular rails, pulmonary edema, F3, MR, chain Stokes, et cetera, from that standpoint. Now, on the other hand, if you look at the right side, you get abdominal pain from congestion, anorexia, nausea, bloating, or peripheral edema, swelling. Physical exam signs, edema, elevated neck veins, abdominal jugular reflex, that actually is the one we talked about, and hepatomegaly, big liver, just related to too much fluid kind of going there. So what's the difference between the two? And this is, hopefully will make sense a little bit. If you look at the RV versus the LV, you see a big difference in the amount of muscle when you slice it this way. If you slice it on the short axis, you see that the LV is really circumferal muscle, and the RV really just has this kind of free-floating wall that goes that way. Now, when the RV squeezes, you get a little bit of this muscle coming together. You get a whole lot of the muscle kind of longitudinally contracting this way. And then you get a little bit of pull right where it kind of attaches to the septum. So the vast majority of your squeeze on the RV is related to this just getting shorter as it goes forward. Now, if you think about the LV, you get different squeeze. LV, you get circumferential squeeze this way, where the whole thing gets smaller. You also get squeezed this way, and then finally you get a twisting motion. You've got these kind of that go that way. So you got 3 different squeezes going on to get blood out of the LV, where the RV just got this free wall out here that just contracts and pushes against the septum. So difference kind of in terms of how they work that way. If you think about what happens when you have fluid, it really, I think, as painful as this is to go through, this is very helpful. So pressure volume loops, essentially you put a catheter in the right ventricle and you load it with more fluid, and then you measure the pressure and see what's going on here. And as you get more and more fluid, you get higher and higher pressures going here in this really steep curve, meaning that for a little bit of increase in RV pressure, or for a little bit of change in volume, you see huge changes in pressure. So when the LV is failing, the blood goes to the lungs. The lungs don't like it. They clamp down in a big way. Goes to the RV, and you get more volume on the right ventricle, which quickly jacks up the pressure on the right side. So what happens in the RV when the pressure goes up? So again, pressure on the volume here, you see a huge, quick reduction in stroke volume, and everything backs up. And it backs up into the belly, and it backs up into the legs. That does not mean that the RV is failing. It just means that the RV can't handle the pressure, and the stroke volume really reduces in a quick way. So a big difference there compared to what you see on the LV side, where you can really jack up the pressure and see just a minimal reduction in stroke volume. So big differences in how they work. That's why you acutely, on the right side, will just get that fluid to distribute to the body, because it doesn't want to hang around in the right ventricle because it can't So is this important, and is RV important versus just saying right-sided heart failure? And I think the answer is yes, because when the RV is pooched, people die. And so if you look at a group here, and this is an old paper that did MUGAs to look at RV ejection fraction via MUGA. And so if the RV ejection fraction was above 30%, you see this survival versus this group with it less than 30%, where really by a year, about 30% are still alive. So once patients truly have RV failure, they're in trouble. And I think that's why it's important to kind of distinguish right-sided heart failure from right ventricular failure, because they get so much sicker with that, and why it deserves a little bit of Jiminy Christmas. So what are causes of right heart failure? Most common by far, left-sided heart failure. Years and years of high pressures, go to the lung pressures jack up, the RV fails, and kaboom, you're in trouble. PE, acutely, will cause RV failure. Other causes, pulmonary hypertension, some goofy stuff, pulmonic valve stenosis, two-outlet RV, a systemic right ventricle where you've got transposition, and the RV is pumping to the body, and the LV is pumping to the lungs. So just over years, it can't handle that high pressure. You also have a lot of volume overload issues, TR, PR, ASDs, anomalous pulmonary venous return, where instead of going back to the left atrium, it comes back to the right side, sinus with valsalva rupture, et cetera, et cetera, et cetera. Ischemia, if you have a big RV infarct, can get you into trouble. ARVD, so arrhythmogenic RV dysplasia, where the right ventricle just becomes fat and a little bit of fiber, will do to you. And then, again, getting to the definition, the right heart can't send the blood to the lungs. If the right heart doesn't see things, that's RV failure, right? So if you've got bad tricuspid stenosis or SVC stenosis, less blood going to the heart, by definition, that's RV failure. And then some congenital funkiness as well, that'll pop up there. So a lot of different ways to determine RV dysfunction. No great ways that we routinely do, right? So we look at the RV on echo and say, oh, it looks hypokinetic or it's dilated. TAPSE, so tricuspid annular systolic excursion, essentially how far does that tricuspid valve get pulled down into the right ventricle with contraction we'll look at. MUGA we don't do very often, MRI we don't do just for that, but both are very good from that standpoint. If you want to stick a catheter in there, elastance, which is that pressure volume, the steep curve there, defines it, as well as preload recruitable stroke work, et cetera, et cetera, et cetera. The big ones we look at is really echo, right? RV hypokinesis, big RV on echo. Think about in terms of RV failure from that. Very busy slide that didn't turn out very well. Essentially, they tried to come up with right ventricular just like LV, where you've got patients at risk for RV failure, those who have RV dysfunction but no symptoms, those with symptoms, and then end stage. The bottom line with all this stuff is here, think about surgery if it's a fixable lesion from that standpoint. Treat with diuretics as much as you can, and then as you get to end stage, heart transplant, lung transplant, and goofy stuff with pH drugs and that kind of stuff as the things that you can potentially think about. A quickie. Right-sided heart failure symptoms and signs, not RV failure. Think about them differently. Case 2. And let's change the age here to 92. 92-year-old female, 2-week history, worsening heart failure, lightheadedness, orthopnea, peripheral edema, EF 15%, second admission 2018, heart rate 94, blood pressure 94, lungs clear, so does not have left heart, signs and symptoms. JVP's up to the earlobe, does have an S3, 2+ edema, sodium 138, K39, creatinine 1.4. On lisinopril, carvedilol, furosemide, Spiro. Which ones do you want to keep going? Blood pressure 94 and volume up. You want to keep the ACE going? Normal outpatient clinic a month ago, blood pressure was 108 systolic.
Is that creatinine there?
Creatinine was, what did I say, 1.4?
She's old. I'd keep them all going.
Increase the Lasix.
nervous about, keep it going.
Increase the Lasix.
So I wouldn't worry about an old lady with blood pressure 94. I'd be nervous. Carvedilol,
She's already lightheaded.
you probably want to stop. Yeah. Furosemide. Hopefully you're gonna say yes. Keep it going. Probably switch it to IV. Spira. Creatinine's 1.4. K was 3.9, I think.
That's fine.
Keep it going. Blood pressure is 94.
You said it doesn't affect your blood pressure.
Okay, excellent. So, real study, and this I counted as point home. Mortality-wise, Spiro is better than placebo, right? We all know that. K does happen a little bit more often, but that's K defined as K greater than 6. Most of us get nervous about K long before 6. And so if you look at a K greater than 5, it's about a 14% incidence with Spiro. So you gotta worry about the K that way. Gynecomastia, 9 versus 1%. Emphasis, expanded that to a class 2 to class 4, or to a class 2 population. You see the same mortality benefit with a plerinone versus placebo. The only big difference in my mind between the two drugs is a plerinone does not cause gynecomastia. Otherwise the same. You gotta be careful with these, and this is still scares me every time I see it. So this is a Canadian study where they looked at the number of prescriptions and what happened after the publication of the Rails trial. So the Rails trial was published, and the Canadians actually read the paper and started using a lot more Spiro. And in the Canadian health system, they can track everything, right? So for the entire country, they can see an increase in the number of prescriptions for Spiro that were used. The problem is that if you look at hospital deaths, it really doubled related to hyperkalemia after the publication of the Rails trial. So they didn't read the paper that closely, right? And in the trial, if you were on K supplementation, it was stopped. In the trial, if you started somebody on the med, everybody had their potassium checked in a week. It wasn't this, oh, I'll see him back in 2 months kind of thing like we typically do. So remember those two little tidbits, because it definitely can interact with that from that standpoint. So what about at Wake Med? And I'm gonna blame Jan on this. Jan has been collecting data in the elderly patients at Wake Med with heart failure. And it's a fairly even split between HFpEF and HFrEF. EF, as you would imagine, is different. Females tend to be more the HFpEFers. Blood pressure in both groups is okay. And this is at the time of admission, heart rate in the 70s, sodium there, creatinine on average about 1.3. If you look at their meds at discharge, ACE/ARB on 53%. This is here. Beta blocker.
This is HFrEF only.
This is
HFrEF only.
HFrEF only, correct. Beta blocker in everybody. Aldosterone antagonist, 25%. Hydrolyl iso, a little bit better. DIG, 5%, very nice. And diuretic in most people that way. So ACE/ARB, ARNI, aldosterone antagonist, HFrEF only. We're not doing a good job here in our elderly patients with heart failure. If you try to look for excuses on why not, those that were discharged, again, HFrEF only, on aldosterone antagonist, potassium, no different whatsoever. Creatinine, a little bit higher at 1.4 versus 1.2, but not like 1.8 versus 1.2. And blood pressure actually, thankfully we've beaten that into you, but blood pressure was actually better in the group that wasn't on an aldosterone antagonist. Another reason not to say kabuto. And of interest, nobody in this group had a creatinine greater than 2. Nobody. So if you start to think about it, most of these patients could probably be on it that weren't on the drug from that standpoint. And you can argue a little bit sicker, you worry a little bit more about them on an ACE/ARB standpoint, but on an aldosterone antagonist standpoint, really not there from that standpoint. Now what about everybody with heart failure? And so this is all comers, HFrEF, HFpEF, 40% with a low EF, not on an ACE-ARB ARNI, 19% not on a beta, half not on aldosterone antagonists. The amount that failed get with the guidelines, 2%. You guys do a very good job of having a reason why they're not on drugs. But we're not doing a great job on not getting them, on drugs. It's like throwing a triple negative in there. And so we're working on this, right? So Jan actually is quitting her job, and changing, thankfully not quitting the hospital. But in March will be no longer kind of basic floor responsibilities and 100% heart failure responsibilities. And so we're gonna try to do a better job of identifying this group of patients that's not on the meds and seeing if we can work to get them on meds before you guys have to do the discharge summary and feel bad about it.
So the ones up there at the top that say not on ACE, ARB, ARNI, were some of them on hydrolysine nitrates? Because that can be used instead of those, correct?
If they absolutely can't take those. It's not an even replacement though. They should be on those if they're appropriate.
Right.
But otherwise,
But I'm just wondering, did you look at that if they were appropriate?
no. No,
Yeah.
because these, sorry, go ahead.
So these are patients that were appropriate for,
Okay.
and it's hard to define appropriate, right? So if you look at a point in time, somebody might have had 2 days of a low blood pressure that made everybody get nervous. And then on the day of discharge, oh, the blood pressure is 110, why aren't they on an ACE-ARB? So this is not perfect data. But there still is a big chunk of patients that never had a blood pressure below 100 throughout their entire hospitalization that we're not sending home on these. We're doing a very good job of giving an excuse for it. And some of those excuses are probably more legit than others. But I think there's room, clearly, there's room that we can get better with this down the road. And it's interesting, right? And this is not only here, this is across the nation. We're get with the guidelines and all that kind of stuff. Everybody is now perfect at, but if you truly dive into the data, this is what you see. You know, and it's the bane and the benefit of Epic, is that you can easily document, but it makes it easy to really not make you take that extra minute to say, should they be on? So it's Jana's job to fix it, but something for y'all to think
Hey, I have
about.
something to add.
Mhm.
Can you go back one slide, maybe?
Maybe.
If not, it's okay. So the ACE-ARB ARNI group, so you mentioned that like their renal function was a little bit worse. And I would make an argument that like 80% of the time when we're not using them for chronic kidney disease, it's bogus. Because ACEs and ARBs are in the chronic kidney disease guidelines, they're in the diabetes guidelines, they're in the heart failure guidelines, they're in the ACS guidelines, but we don't want to use them in patients have heart failure and chronic kidney disease. And that makes no sense as long as they're stable. So I know a lot of people inpatient have fluctuating renal function and I get that, but I think a lot of times it's carried over. You know, I'll read notes from 2016 where we're saying the same thing, and I think we could give those patients a shot. Because if they're stable at 1.54, they would probably really benefit from being on it.
Yeah, and nephrologists are starting them in patients with creatinine 3.5.
Mm-hmm.
Yeah.
Especially if their potassium is okay.
Yep.
Right? Like if they have a potassium of 3.5 or something, then we could try that.
Yeah, we already got over that. So, how do you classify peripheral edema? Let me back up a slide before you go up and cheat.
Can't see it, that's good.
Oh, man. So how do you classify peripheral edema? This physical exam, believe me, there is no right answer. As I learned, as I was trying to what I've been taught and find the data to support that.
So I usually say like pitting edema and then to where. I don't typically do 1+, 2+, 3+. So I'll say pitting edema to the knee or the leg.
How long was the invitation?
How long it lasts, how long the dent lasts.
But I don't sit there and count either.
So here's a couple of kind of common things. So 1+, barely detectable. 2, slight, that takes 15 seconds to rebound. 3, deeper, 30 seconds. And 4, greater than 30 seconds. A different one that really gets into measurement, 2mm, 4mm, 6, and 8. With time, that's different, right? 20 seconds versus 30 seconds. And nobody knows, right? And there's no data to support either one of these. So these guys, it's really kind of a cool thing, took patients and did 8 different ways of trying to figure out what's the best way to classify edema. So they did the pitting depth, they did ankle circumference, which you really chronically need, right? One-time ankle, who knows what that means. Figure of 8, which was just measuring at 8 different spots around the ankle, so similar kind of thing as circumference. The edema tester, which is right here on the right, which I'll talk more about. The modified edema tester, foot angle volume displacement, so they put the foot in water and measure how much it is. Indirectly measured leg volume, and then ask the patients, are you swelling or not swelling? So this edema tester is plastic, and you put it on the leg, and you blow up a blood pressure cuff around it at 50 millimeters and leave it on for a minute. And then you take it off, and you measure how many of the holes actually show up. And so the more edema you have, the more holes you have that show up, right? The modified one has bumps instead of holes to do this. So serial exams, multiple patients, you get a paper out of it, right? So the 2 best ones, actually, ankle circumference, can't do it. I mean, serially, I think for our patients, it'd be something where we can start to add, weigh yourself every day, check your blood pressure, and measure your ankles. But yeah, good luck with that. And then stick them in a bucket of water and look at volume displacement. So how much fluid do you have to put in your legs to have peripheral edema? 10 pounds. Going higher or lower? Lower.
Lower.
So fascinating thing, that's exactly what the books say. 5 kilos, 4 to 5 kilos of fluid before you truly get edema. Again, nobody's really measured any of that stuff that well. But you need to think about it, that once people start to put on fluid, they probably do have at least 5 or 6 pounds, if not more, of extra fluid that they're living with from that standpoint. So how was I taught to measure edema? And it's really about where it is, right? At the ankle, below or above the knee or the sacrum. And I tried really, really hard, looked through about 5 books, and I couldn't find the reference to this. So I'm gonna keep looking until I find it. But I think that pitting is one thing, how high up it is probably more helpful in terms of getting a feel. So if you truly have somebody with sacral edema, that means a lot more than 4+ only at the ankles. If your 4+ it's there for 30 seconds, da-da-da-da-da. So however you want to quantify it, 1 to 4, at least tell how high up it is, because I think that is something that we all kind of understand, and that massive edema